great privilege to be here. I was planning to travel to Lagos for this talk. Maybe next year we can do that. And my title is Safety and Quality of Care as Drivers of Bloodless Medicine. So here we go. My disclosures. I'm on 3 different committees for 3 different societies on patient blood management. And I want to start with a little history of Johns Hopkins, because Denton Cooley, who did his surgical training under Alfred Blalock at Johns Hopkins, is considered to be the father of bloodless medicine. He did med school and residency at Hopkins. He's pretty well known for the first artificial heart implantation, but most importantly, about 45 years ago, he had this paper in JAMA of over 500 cardiac surgery patients without transfusion. And this was a 20-year series of patients. So these patients go all the way back to 1957. And he was doing surgery without transfusion way back then, before the cell saver was even invented. So this is the history behind bloodless medicine, and he is considered the father of the specialty. So at Johns Hopkins for about the last 9 years now, we've had a program for patients who wish to avoid transfusion, and we call it the Center for Bloodless Medicine and Surgery. And I'm going to share with you our experience of how this happens and how we optimize care for patients. So the first lesson is that bloodless care is not simply withholding blood. It's much more than that, as you'll see in a minute. In fact, bloodless medicine has a lot in common with patient blood management, or PBM. They share many overlapping principles. Only in one program, you aim to avoid transfusion. In the other program, you aim to reduce unnecessary transfusions. And we really use many of the same principles, as I'll show here. So who is it that can't be transfused? Primarily at our institution, about 90% of the patients wish to avoid transfusion for religious reasons. But also we have patients with alloantibodies and or personal preference to avoid blood. And then, of course, when no blood is available, like in remote regions. And here's the background behind the Jehovah's Witnesses decision to avoid blood. Ever since 1945, this is the belief of Jehovah's Witnesses, and this is the 3 passages in the Bible where this belief comes from. Fascinating to me that in the Jewish religion and even in the Muslim religion, they drain the blood out of the animal before it is slaughtered. And I believe that this comes from the same place in the Bible where Jehovah's Witnesses decide that they will not consume or receive a transfusion. So what will Jehovah's Witnesses generally accept or not accept? So red cells, plasma, and platelets, and white blood cells or leukocytes are definitely off limits. They will not accept these components. However, all other factors like albumin, immune globulins, even prothrombin complex concentrate, or hemoglobin-based oxygen carriers are considered to be a personal choice. So each patient has to make their own decision over whether they will accept the entities in the green arrows, but the red arrows are off limits. So this is a graph showing the risk of blood transfusion from the blood banks over the last 40 years, roughly. And so we used to think that Jehovah's Witnesses were kind of crazy until about 1984, when it was the most dangerous year to have a blood transfusion ever, because the risk of hepatitis C and HIV were about 1 in 100 transfusions. So you had a 1% chance of getting either one of these life-threatening viral diseases from banked blood. And it wasn't until 1985 and 1990 that the tests for HIV and hepatitis C were widespread and the blood got safer. So we've had a program at Johns Hopkins Hospital for about the last 9 years to reduce unnecessary transfusions for all patients in the hospital. And this is our patient blood management program. And we published on methods to run a patient blood management program, everything from support from leadership of the hospital on down. And there's about 22 methods that we use to reduce unnecessary transfusions in the patient blood management program. And it turns out that 12 of these 22 methods involve what I call keeping the blood in the patient. We'll go through those methods in a minute. More recently, just this year, Nicole Gwynn from Duke and Linda Resar from hematology at Johns Hopkins and I had a short review article on managing patients for whom transfusion is not an option. And in this paper, we outlined the methods to avoid transfusions in the preoperative, intraoperative, and postoperative setting, and how we manage these patients who can't be transfused. And it turns out that 12 of the 16 methods in this table, again, involve keeping the blood in the patient. And we're going to talk about that for a minute. Keeping the blood in the patient. This is our motto at Johns Hopkins. I even tell surgeons the night before the case by email that anything we can do to keep the blood in the patient is a good idea. In fact, one thing that I've noticed over the last decade is that blood loss during surgery is sometimes indirectly proportional to how hard the surgeons try. In other words, when they know they can't lose blood and they know they can't transfuse a patient, they try harder and they lose less. And this is a known phenomenon that we've seen, especially in Jehovah's Witness patients. So speaking of keeping the blood in the patient, this is the type of surgeries that we've been able to accomplish at Johns Hopkins. This is a really complex multi-level spine fusion with a lumbar interbody cage. So this is a really high blood loss surgery, but I counted 8 different devices that our surgeons use to keep the blood in the patient. Everything from a bone scalpel to a saline irrigated bipolar cautery device to a bear hugger or a forced air warmer to keep the patient warm, and then different types of cauteries and other devices to reduce bleeding. So what about simple methods that we've known about for years, like maintaining normal body temperature during surgery? Well, it turns out that even at 36 degrees centigrade, that's only 1 degree centigrade of hypothermia, patients lose more blood. We've known for years patients bleed more below 35 degrees, but this is evidence that they even bleed more below 36 degrees because bleeding in this meta-analysis, even with mild hypothermia, was increased by 16%. And the relative risk of receiving a transfusion with only 1 degree centigrade of hypothermia was 22% higher. So if we can patient's body temperature is above 36 degrees centigrade, we can reduce bleeding. And this is a simple maneuver that we do all the time. So what about the cell saver? This is what it looks like if you've never seen one. Also called autologous blood salvage. So this is a machine that collects blood that patients lose during surgery. It washes the blood in a centrifuge and removes any debris from the surgical field. And then we give patients back their own blood rather than someone else's blood from the blood bank. And I haven't yet met a patient that wouldn't rather have their own blood back compared to someone else's. And we've written a couple review articles on cell savers. There's really 4 different devices now in the US market shown here. And in terms of conserving red blood cells, this is really one of the first lines of defense that we have to do bigger blood loss surgeries in patients who won't take banked blood. So we've even shown that cell saver blood is higher quality than banked blood. We measured 2,3-DPG levels shown in green in cell saver blood, and they were identical to fresh pre-op patient blood, but banked blood or stored blood was 95% depleted in 2,3-DPG, which causes a left shift in the hemoglobin oxygen curve shown here. So banked blood or stored blood is less shifted, which means that it's less able to unload oxygen at the tissue level. So cell saver blood is definitely higher quality than banked blood because it hasn't been stored in the blood bank for up to 6 weeks. And our paper was written up in the media about recycled blood or cell saver blood being higher quality than donated blood or banked blood. And they said, we recycle a lot of things, paper, plastic, metal, and we can also recycle blood and give patients back their own blood. So what about phlebotomy blood loss? We took a survey in the 5 adult ICUs at Johns Hopkins of how much blood patients lose every day to phlebotomy. And it turns out that about 60 mLs a day are either sent to the lab or thrown in the trash as wasted discard to clear the lines to draw an undiluted sample. So 60 mLs a day is just over 1% of a 5-liter normal patient's blood volume. If you're a small patient, it could be up to 2% of your blood volume. So in the neuro ICU, however, they use these inline devices to reduce the wasted discard, and they cut blood loss in half. But pretty much across the whole hospital now, we switched to smaller phlebotomy tubes, and that's the pediatric size tubes shown in the middle here that hold between 2 and 4 mLs roughly. We don't use the adult size tubes if we can avoid it. And sometimes we even use neonatal tubes that hold only 0.5 ml, especially for our Jehovah's Witness patients. So another method to keep the blood in the patient is tranexamic acid, which is now being called a game changer, especially in the orthopedic world. When we started using tranexamic acid for our joint replacements, we saw this dramatic decrease in red blood cell utilization. We also hired 4 new surgeons at the same time, and a large randomized trial came out in the New England Journal about then. So tranexamic acid definitely played a role. It's a drug that's been around for 50 years, but only in the last decade is it being used to reduce bleeding and transfusion. And it reduces both by about 30% if you look at all the studies. So what do we do if we have life-threatening hemoglobin levels that are low for example, below 5 or even below 4, and we're worried about patients who can't be transfused. Well, there are hemoglobin-based oxygen carriers that are not yet FDA approved. There's only one that's now available. That's Hemopure, or HBOC 201, and we have expanded access use approval from the FDA to keep Hemopure in our blood bank, and we've given it to the last 3 patients with hemoglobins less than 5 received Hemopure, and all 3 of them survived. So we're learning how to use it, and if you give it at the right time to the right patient for the right reason, it seems to be very efficacious. One of the methods that we use to manage patients that won't take blood is to optimize their pre-op hemoglobin. And we derived a novel formula to calculate the target pre-op hemoglobin that we need for a given patient having a given surgical procedure. And what we did is we took the allowable blood loss formula and we turned it upside down. It has the same variables like estimated blood loss, desired post-op hemoglobin, and patient body mass. And if you use this formula to calculate target pre-op hemoglobins, you can generate a graph like this. So, for example, if I have a 100-kilo patient, kilograms are on the x-axis, who's going to lose a liter of blood, I only need a pre-op target hemoglobin of around 8. But if I have a 50-kilo patient down here with an expected blood loss of a liter, I need a target pre-op hemoglobin of about 12. So we've used this algorithm to optimize patients' hemoglobin so they'll tolerate the amount of expected blood loss for a given surgery without transfusion. We also have an erythropoietic order set that we built in our Epic EMR system. So we have recommended doses, routes, and frequencies for iron intravenously, erythropoietin, which we prefer to give intravenously, not subcutaneous, and also folate and B12. So sometimes we modify these doses depending on the patient, but this is our standard order set that a lot of the physicians now at Johns Hopkins know about and use routinely. So what about outcomes for patients who can't be transfused? This is back in 2014 when we took an early look at outcomes for patients in our bloodless program. And we looked at ischemic, respiratory, renal, thrombotic, and infectious events in our bloodless patients compared to controls. And we essentially found they did just as well or better. There was a trend towards less infections, and there was a lower mortality rate, but we only had about 300 bloodless patients at the time, so we weren't powered to look at mortality. We also looked at charges and costs for bloodless care, and it turns out there was about a 12% lower dollar figure for charges and costs for bloodless care compared to controls. So this is definitely a cost-effective method of managing patients. So just recently, we updated our bloodless outcomes analysis because now this is about 8 years later. We have 4 times more cases, more years of enrollment, and our methods of treatment are refined. So here now we have over 1,000 bloodless patients compared to controls. And you can see of all the bloodless patients in the hospital, about 13% required IV iron, but only 2.3% required erythropoietin. So not everybody needs aggressive treatment. But here's the outcomes. We looked at composite morbidity and mortality, and the bloodless patients do as well as controls overall. However, when we looked at subgroups of medical and surgical patients, there was a lower incidence of hospital-acquired infection that translated into a lower morbidity rate for the bloodless patients compared to controls. And mortality was no different, but morbidity was decreased in the bloodless medical patients. And here's the composite components to the infection and thrombotic event, renal, respiratory, and ischemic events. So here we found less hospital-acquired infection in the bloodless patients, probably because banked blood is an immunosuppressant. So banked blood does predispose you towards hospital-acquired infections. And if we can avoid banked blood, we can lower the infection rate. What about pediatric patients? This is a brand new topic that not many people have looked at, because pediatric patients, at least in the United States, are very special when they come from Jehovah's Witness families, because parents are not allowed to refuse life-saving treatment in the United States for their children if they're under age 18. So we have about 200 pediatric patients now from families who wish to avoid transfusion. And we tell them, okay, we'll do everything we can to avoid blood transfusion. We'll use the cell saver, we'll give them iron, we'll use tranexamic acid, we'll keep them warm, we'll do all these things, but we can't guarantee you, if the child's life is threatened, that we'll avoid blood. So it turns out that only 5% of our roughly 200 patients required any type of allogeneic blood component when they come in as a pediatric patient. And by the way, they do as well or better compared to matched controls of similar age, especially when it comes to composite morbidity. Their morbidity was less than half of that of controls. So what about giving less blood to other surgery patients like pancreatic surgery? We do perhaps more pancreatic surgery at Johns Hopkins than any place in the world. We do about 400 Whipple procedures a year. Sometimes we do 3 in a day. And so we looked at 10 years of pancreatic surgery to look at trends in overall blood utilization. So if you look at before blood management, early blood management, and then after mature blood management, we reduced red cell transfusions by about 50%, but plasma and platelet transfusions we've reduced by 80 or 75%. And so we're definitely doing these big surgeries like Whipple's with a lot less blood than we used to. In fact, we're tolerating lower hemoglobin triggers and targets. You can see the hemoglobin trigger and target fell by about 1 gram. And when we look at outcomes, the patients are doing better, even with less blood. Mortality was unchanged, but a trend towards decreased. Any morbidity, infection, thrombosis, renal and respiratory events, all improved with patient blood management. And we're now seeing better outcomes with less transfusions. Like I said, however, giving bloodless care is not simply withholding blood, it's more than that. And this is the guy who delivers blood to Johns Hopkins twice a day from the Red Cross. Every time I see him in the hall, I asked him if I can take his picture, and he thinks I'm kind of crazy, but this is the impact of patient blood management, as you can see. And then with bloodless care, we have this going on. We can actually deliver better care to patients now more than ever without transfusion. And like Bruce said before me very nicely, patient blood management and bloodless medicine are now more important than ever because of the severe blood shortage we find ourselves in related to the pandemic. And I'm going to quote one of my favorite pancreatic surgeons on how to stop surgical bleeding, pressure patients' prayer, proline, plasma, platelets, and even PCCs. But perhaps for patients who don't want allogeneic blood, we could avoid plasma and platelets. And running a bloodless program is definitely a team sport. I want to thank all the people on the Johns Hopkins bloodless team, Andy and Joan. I want to thank Isha and Linda and Liz, Kevin. This is our trip to Warwick to visit the Jehovah's Witness headquarters at the Watchtower. And we spent a day with the hospital information services, sharing our most challenging cases and how we manage them. And we have an exchange of ideas between the medical professionals at the Warwick headquarters and then with our staff at Johns Hopkins. And I think we'll end here and have plenty of time for questions. Sometimes I feel like this in the hospital at work, but lately our patient blood management program and our bloodless medicine program are both running smoothly side by side. And I think each program learns and benefits from the other to either reduce unnecessary transfusions or avoid them completely.